We'd like to thank SAGES for the opportunity to present our work. This study was partially funded by the SAGES Robotic Surgery Research Grant, and we would like to thank the research committee for their support. Laparoscopic bariatric surgery has become the gold standard for durable long-term weight loss. In recent years, use of the robotic platform has increased given theoretical advantages in ergonomics, three-dimensional imaging, and dexterity. Widespread adoption in bariatric surgery has been limited, partly due to the lack of a clear established advantage over laparoscopy and concerns over increased cost. Early outcomes in bariatric surgery have been variable, including longer operative times and equivalent to slightly increased complication rates with the robotic approach. Many early studies were limited to retrospective reviews or meta-analyses, including small, single institution or single surgeon studies. None have evaluated the longitudinal trend in outcomes that could arise from increased experience and changes in available technology. This study aimed to use MBSAQIP data to compare nationwide trends in utilization and outcomes improvement for robotic and laparoscopic bariatric surgery over a 4-year study period. MBSAQIP data files were used to identify all adult patients who underwent robotic or laparoscopic sleeve gastrectomy or gastric bypass between 2015 and 18. Patients with previous bariatric or foregut surgery were excluded, as were those with conversion to open surgery. Specific perioperative and 30-day outcomes were compared as listed. Patients in 2018 were then selected for subgroup analysis to compare each outcome among different surgery types. This was done to closely report near real-time results. During the 4-year study period, over 570,000 patients underwent bariatric surgery, of which almost 47,000, or 8.2%, were performed robotically. Utilization of the robotic platform increased annually, from 6.7% in 2015 to 10.3% in 2018. Case distribution of sleeve versus bypass were similar in the laparoscopic and robotic cohorts, with the majority of patients undergoing sleeve gastrectomy. Patient demographics are reviewed here. While there were statistically significant differences in baseline characteristics, the clinical significance is likely minimal. In this figure, trends in laparoscopic outcomes are reported by a solid line, and robotic outcomes in a dotted line. In general, perioperative outcomes improved over time for both robotic and laparoscopic procedures. Most differences were not statistically significant. However, improvement was more pronounced in the robotic cohort for extended length of stay. Additionally, despite higher absolute numbers, improvement in operative time was significantly greater with robotic surgery. This may underline that robotic surgery is earlier in the adoption phase. The fact that improvement was seen with laparoscopy shows that even for an established procedure, there are ongoing improvements with time and experience. In the 2018 subgroup, we found a differential impact of the robotic approach depending on the procedure performed. We found leak rates for robotic and laparoscopic gastric bypass to be equivalent, and overall complications to be greater with laparoscopy, likely due to the increased risk of bleeding, which is twice that of robotic gastric bypass. Laparoscopic sleeve gastrectomy was associated with decreased leak rates, 30-day readmissions, 30-day reinterventions, overall events, and extended length of stay. Across the board, laparoscopic surgery was associated with decreased operative time. In examining these outcomes, we propose a few hypotheses. With regards to the increased risk of leak with robotic sleeve gastrectomy, prior to 2019, a stapler was not widely available on the robotic platform, and all stapling was performed laparoscopically by a bedside assistant and not the operative surgeon. This lack of control of the stapling device by the operating surgeon may account for the difference in leak rates, although there is no direct data to verify this. If this is a large contributor, future studies including sleeve gastrectomy procedures performed with the use of the robotic stapler should provide some insight. Additionally, it is possible that sleeve gastrectomy is initially the procedure of choice for surgeons early in their robotic experience, which may contribute to these worse outcomes. The increased risk of bleeding with laparoscopic gastric bypass may be attributed to the hand-sewn anastomoses commonly performed robotically, whereas many laparoscopic gastric bypass procedures are performed with stapled anastomoses. Further data are needed to validate this hypothesis. Finally, the increased operative time with robotic surgery is usually due to time required for docking and instrument exchange, which should show improvement with newer generation platforms. As newer data become available, we can potentially see the gap in operative time close. There are some inherent limitations to our study. As with any large database, it is easy to find statistically significant differences which do not translate to clinical differences. As such, these data must be interpreted carefully rather than being taken at face value. Additionally, outcomes data beyond 30 days and data on surgeon volume or experience, cost, or specifics of operative and anastomotic approach are not available. Finally, these data were collected prior to widespread adoption of the newer robotic platform and availability of the newer automated robotic staplers. As newer data become available, outcomes may change accordingly. In conclusion, robotic utilization for bariatric surgery is increasing and outcomes continue to improve with time. Outcomes are dependent on the specific procedure and approach, suggesting that broad conclusions regarding the use of a robotic platform cannot be generalized to all of bariatric surgery. Future studies are needed as newer generation robotic technology become available. For a more detailed review of the data, please see the corresponding manuscript, which has been accepted for publication in Surgical Endoscopy. I'm also happy to answer any questions through the platform or via email.